Hello, and sorry not to be able to be with you in person. My name is Isabel Hodkinson. I'm a Tower Hamlets GP, that's inner London, and I was involved as the diabetes lead for Tower Hamlets from 1993 to 2011, and I'm now on the CCG board with the lead role for informatics. So I was particularly asked to talk to you about the work that we did around making a big difference to the care that people living with type 2 diabetes now have in East London as compared to 10 years ago. So I'm going to start by a little bit of scene setting. Tower Hamlets is a very deprived borough, although demographics are changing with the river edge being developed into swanky apartments. So we have very wealthy, very expensive apartments on the river edge with a block in some of the most deprived estates in the whole of England. I know we can't compete with you in Glasgow. And we also have a massive multi-ethnic population. Tower Hamlets particularly characterised by a significant Bangladeshi population. So this heat map just shows Tower Hamlets with a jigsaw puzzle shaped piece in the middle. And we have the Isle of Dogs, which is where Canary Wharf is the sort of tooth of the jigsaw puzzle, not so deprived. But then this massive heat band across the middle, which is this big band of deprivation across the middle of the borough with very high levels of diabetes. And just to set into context, just across our boundaries east of our boundaries is the Olympic site. So our starting point 10 years ago, so obviously 10 years ago, 2004, nationally in England, we introduced the Quality and Outcomes Framework. And we also locally started introducing a local enhanced service from 2004, trying to have a much more joined up service, but also to encourage practices to take on full care for people with uncomplicated type 2 diabetes. And we'd already developed a community diabetologist role and diabetes specialist nurses to try and support that delivery, although many practices, and often the practices who most needed to, really didn't open the door to them, whereas other practices who actually were fairly well sorted would use them quite heavily. And I think there was also a sense that perhaps very often practices handed over the delivery of care for diabetes to the specialist team rather than using them in a supportive way. We'd also done quite a lot of attempts to quality improve visits, training, taking around benchmark data, both in terms of diabetes-specific work, but also in terms of some wider developmental work in practices that were struggling. And in general, the observation was that you did make a difference while the resource was going in, but things then tended to default back to what they'd been before once the project stopped, so what I would call projectitis. And indeed often the memory and learning from one project to the next was lost. The other thing that we began to notice was that actually people who were not very good at doing care for people with type 2 diabetes were often not very good at doing general practice altogether. So this slide, sorry, is a very busy slide, but in essence you've got 2004, 5, 6, 7 RAG scores for diabetes QOF. And anybody who at any point scored anything other than green is on this chart, so not the entire group of practices for Tower Hamlets. And anything on the left that's now flagged purple are practices that got decommissioned. So a lot of the practices that decommissioned were also struggling to deliver. Having said that, I've got two practices flagged green on the left who were practices that were struggling massively, but actually were able to pick up and run with the mentoring and improvement packages that the PCT was offering and have made sustained improvement, and they are still in business to this day. This process actually decommissioned 11 practices. And I'm going to come on and talk about our development of networks, and I think that this was an essential precursor step and was a very difficult job led by our very visionary medical director. So there's something about actually moving away from perhaps a degree of collusion between us and our colleagues when you're faced with very poor practice. That was very tough. This is data from the 2006 PICA survey that was done again nationally in England. And I was very impressed by the PICA people when they managed to positively reframe this, which is pretty terrible. So basically just showed that at the time, most people living with type 2 diabetes in Tower Hamlets were clueless. The positive reframing wasn't it great that people in Tower Hamlets were so keen to learn more about their diabetes? I think the interesting thing here to note is the one about alcohol. That looks good, but just to remind you that we have a large, ostensibly Muslim group of people with type 2 diabetes. So I think that's why the alcohol one doesn't register. But pretty much across the board, we're looking at people desperately needed to know more about their condition. So by 2007, we really got to a position where we really knew that something had to change, but we didn't quite know how to change it. We had a very clear burning platform, and actually this was kind of also seen as something that was about almost neglect of this ethnic minority who have a 6 to 7-fold increased risk of type 2 diabetes, and genetically are much more difficult to get good glycemic control in, and also are strongly predisposed in particular to nephropathy. Building on the GP involvement and GP development work, we really had come to a place of saying, if properly trained and supported and resourced, general practice should be able to be the core delivery place for care for type 2 diabetes, that they shouldn't have to be hived off into a diabetes service. We absolutely recognise the need for masses and masses and masses more education, at the time largely in relation to people living with diabetes, but also in relation to teams delivering for diabetes. And actually we really didn't know how. So our very visionary then diabetes nurse specialist lead actually put us in for the Diabetes Year of Care pilot. And this was the summer of 2007. And I can remember having just finished the interview with the selection panel saying, it's crazy us doing this here, you know, our patients will never get this. And so I think that assumption that because our population is deprived, that in a sense we won't be able to make changes to that is an assumption that I'm very happy to say I was wrong about. And I'm going to lead you through the journey that we went on from that. Okay, so what we actually became involved with was, over the next 4 years, 2 huge transformational pilots. The first one was we did become one of the 3 pilot sites for the Diabetes Year of Care programme, which covered only a quarter of the borough, that's 8 practices, but focused on really shifting the culture and structure of the annual review for people with type 2 diabetes to this care planning approach, which was about building a collaborative partnership model with people living with type 2 diabetes, and I'm going to come and talk about that in a little bit more detail. But there was so much interesting learning that came out of that, that although there were a number of other drivers for developing the Department of Health Integrated Care pilot that we then went into from 2009, in fact, the model there around, in a sense, putting practices into networks and putting in incentives and enablers to standardise and improve practice across the board, it was a kind of a no-brainer that diabetes was the first clinical package that we went down, because of all the learning that had come out of the Year of Care programme. And then since then, that same delivery mechanism has been used to roll out a number of other programmes, but diabetes was the first. So the Year of Care programme had at its heart this concept that actually the people who live with their diabetes are the experts in them. So they may need help with their diabetes, but they are the ones who know what works for them, what doesn't work for them. So not only did we do a lot of public-facing sessions, in a sense, around co-design and understanding what people wanted and needed, there is also at the heart of the transition that we made the idea of developing almost like a day-to-day model of partnership working. So crudely speaking, what we did was take our current model of annual review and change it into this more complicated structure, which involved a first visit, usually done with an HCA, which was involving collecting all the process of care, the blood pressures, the weights, the blood tests, the foot checks, in essence ticking the boxes. Then, very crucially, wherever possible, feeding back the results of those things with some kind of reflective prompts to the person living with diabetes, perhaps a week or so before they then came back for visit 2, which might be 3 or 4 weeks after visit 1. And that this is a visit where really the decks have been cleared for a partnership conversation, hearing from the person with diabetes what's important to them, explaining to them what's important from the professional point of view, and then in a sense coming together to work out what the next steps are. And very crucially, and kind of when I think back on it now seems like a no-brainer, this is about understanding that if we want to see behaviour change, or indeed in adult learning, the same idea, we have to start with that individual, where that individual is. So giving, quotes, education, close quotes, which is about what we think they need to know, when their head is somewhere very different, just doesn't work. And having space for these conversations, which are starting where they are, has made an enormous difference. We do have more time. So one of the big areas that we had to invest in was that consultation, usually about half an hour. The outputs from that are actually about what the next steps are. And very crucially, largely they're about what the next steps are for the person living with the diabetes, although there will, of course, be some next steps in terms of professionals. But where possible, we were trying to develop, in a sense, clear, achievable next steps to build people's confidence, helping them to succeed in what they planned. And so trying to set smart action plans with them. And I think if you've come across, if you've done personal development plans for your appraisals, I mean, it's that kind of model. We needed to find ways of communicating with people, and we have a group who either do not speak English or are not literate, and that applies to both English and non-English speakers. So this model was our results letter, which was developed by a media company with a group of users. So very visual, trying to make it quite a powerful impact. So as well as the learning we had around, we absolutely had to work with the people that we were trying to deliver the services to, both in terms of planning the service, but also in the day-to-day delivery. We also needed to really engage staff. This is quite a significant culture shift. So a lot of people to stop saying, oh, you can't give people those results, that'll get them upset. So actually, we started by doing a reflective tool with the practice teams. Quite interestingly, on the whole, GPs think they're doing this already. But when you then line that up against the feedback from the patients, we really are not doing this already, and largely around decision making. So we might consult in a person-centred way, but when it comes to what the next steps are, people tend to get told what to do. So we started with clinical training, and we started trying to roll it out. But we then realised that actually this is such a complex system change that unless we really have clear explanations to the wider practice team, particularly the call and recall teams, but also the reception and management staff, and that you didn't get a coherent message. So we found that the 2-hour taster session for the wider team was really invaluable, because then you had that kind of coherent message for people on the receiving end. As I said already, we developed HCAs to be able to do as much as possible of that part 1 visit, really for cost effectiveness. And then very crucially, we needed to develop ongoing learning, because this was something new that we didn't know how to do. So we developed this model around peer support and review, and again that it was clinical and non-clinical at the same time, and very consciously tried to talk about the culture and attitudes that lay behind our care. So I've talked about this shift in partnership, having time for this consultation. So the other thing that we learned in our journey with that initial year of care pilot was that actually there were 2 other very crucial components to this, and this need for a coherent system was described by this, which is the year of care house. So the first was that when we went around practices, we actually found all sorts of things going on. So for example, Band 7 nurses sending out invite letters for patients, practices not knowing anything about the massive array of community and voluntary sector resources that could be of value to their patients. Very fragmented working, so people never saw the same doctor or nurse twice. People really not understanding what their achievements were. So other than having QOF, which is a very poor mechanism because it's basically just based around payments, that you couldn't see the wood for the trees. So the Year of Care House really describes that it's crucial to have solid organisational process and commissioning processes, and you've got to do some of all of it, because if you do fantastic work around engaging and informing the people living with diabetes, but actually they then come into a consultation that's too short, that the healthcare professional doesn't want to work with them in that way, then the whole thing falls flat on its face. So it's really important to think systemically. The kind of aligned commissioning we embarked on, so we already had this community outreach diabetes model, but we moved it to a much more facilitative model rather than a care delivery model. We started thinking much more strongly about the supportive services. We were getting feedback back through the care planning, for example, about Muslim women needing female-only exercise opportunities, cooking clubs, healthy gardening. So the things that people actually wanted to do rather than some of the things that we as professionals thought they ought to do. We actually have a very vibrant community and voluntary sector in Hamlets. So we developed a catalogue initially on paper, ultimately online, to give people we were calling at the time the menu of care. And actually that journey around the community assets was we developed public health posts, so one for each pair of networks in the locality, trying to foster engagement with the community and voluntary sector and link them up with what was going on in the statutory services. Okay, so moving on into 2009, as I said, that the PCT then became one of the Department of Health integrated care pilot sites, and having recognised that actually mainstreaming stuff into general practice that perhaps historically had been done as secondary care, and we had a tag phrase, care closer to home, needed general practice to have enough resource to deliver. So the PCT had some growth money at that time, and they chose to put pretty much all of that growth money into primary care, but they wanted to make sure that it was going to be used in the way that they wanted to be used, so they put it into primary care in a very structured way. So the first step was that in order to be able to earn this money, you had to work in partnership with the other GP practices in your geographic locality. You couldn't work with just your mates, you had to work with other people who were in your local area, and these were coterminous with the way that the borough had chopped the things up. So most of them were about 25,000 to 30,000 patients. The other big piece of infrastructure that we put in was what we call dashboards, and this was building on the model that we had about data-driven quality improvement, but also professionalising the call and recall. So we had a central GP academic unit who support our data collection, and so they would write the searches and the code templates, but we would then stream all our data, and we're all EMIS, we stream all our data up into a data warehouse so that they can then generate performance dashboards which are generated on a monthly basis. So the same searches that drive call and recall would also drive the performance feedback and ultimately payment. And the payment was predicated on 70% of the total package cost was delivered up front without paying for staff, but 30% was performance-related pay, which would be delivered after the year end, and crucially was predicated on the performance of the entire network. So you really suddenly got very interested in peer learning and supporting your colleagues to develop and improve. And the network had the power to decide how to distribute any of that money. So, for example, some networks chose to hire a diabetes nurse specialist across the network to deliver it. Other networks chose to run most of this through the local practices. So it was a very locally owned and locally driven delivery programme. So there are the 8 networks, 4 or 5 practice in each, as you can see, very variable populations. So we know from the 1980s that diabetes care needs to be structured and systematic. At the heart of our programme was supporting self-care by people living with diabetes. We'd understood that we had to shift the entire system, that we just tried to do bits, it just reverted back. So we needed to do something system-wide, and that meant that we had to do it big, so we did it at scale. We were very clear about what people had to get, so we specified in some detail for different people at the different stages in their diabetes journey, and that we needed to build in ongoing learning and pulling specialists out into the community near to where the people are, both clinical teams and people living with diabetes, So we had this strong specialist and peer reflection as support model. Okay, so I'm now going to move on to what happened. Pretty much a very good outturn. Better experiences by staff and patients. Much, much better processes of care. We really professionalised our call and recall. And actually when we first started, I mean, if you don't even see somebody, and so when we started looking at this in 2008, I think it was, on a 15-month year, which is the way the QOF works, only 88% of people had actually had their processes of care done. So never mind what the actual measure was, they hadn't even had their blood pressure measured. It's now 95% or so. And also just getting the care planning done. It's now part of the norm. People do care planning. The quality perhaps is more iffy, and that's another area we need to keep working on, because sustaining that culture shift isn't always easy. And then I'm going to show you what our proxy outcomes are. What I put timescales, the reason I'm talking about proxy outcomes, stuff that we really want to see a difference in terms of heart attack rates for renal replacement. We said to the PCT at the time, we don't think that you're going to see impact in those areas for 10 to 15 years. And most untypically for most commissioners, they said that's fine. So there's something about having sufficient, having the oomph to allow for sufficient timescales for these kinds of interventions to begin to really kick back. So experience. Going back to my comment about, our patients will never get this. Actually, what's amazing is that having time benefits probably the disadvantaged most, because most of them are not in a position to be able to use statutory structured services. So having that conversation about, where they are now and where they might want to go to next works really well. It's kind of building the services out from their needs rather than expecting to fit in, so that one size doesn't fit all. And some of the very difficult situations that these people are in, and being respectful for what's important to them, but also trying to take them on a diabetes journey, that's very powerful. I think it's also really much better for us as professionals, because there's better time, but also instead of trying to sort of bully somebody into sort of jumping through a hoop, it just has a much better quality of respectful humanity. So it actually fits some of the compassionate care conversations that we've also heard about. And then there's space for actually people to say, you know what, I'm just not going to take those statins, and being able to respect that. This slide, this was actually the second package we put in after diabetes, which was childhood immunisations, enhanced childhood immunisations. And this just to show that actually a lot of what we did was about really much slicker call and recall in terms of getting processes done. So I think in London it was felt that it was going to be impossible to ever achieve a 95% MMR coverage, and we did it within a year of go live. So a lot of that was just about getting really slick about call and recall. These are the proxy outcomes. So again, we were always doing quite well around blood pressure, but it really kicked off. And similarly for cholesterol, and for the last 3 QOF years, so 13, 14, 12, 13, 11, 12, Tower Hamlets has had the best blood pressure and cholesterol rating across any CCG in England. And sorry, this isn't a very good chart, but basically this is shows, it just happens to be cholesterol, but the blood pressure one looks very similarly. The performance by London CCG against the England average. And I just wanted, this is us in Tower Hamlets. So way, way, way out beyond, many, many standard deviations away from the England mean. And interestingly, this is Newham, which is our neighbouring borough to the east. And although they haven't had the financial and strong network framework that we have, they have used our dashboards. So I think that might have had an impact. Who knows? Glycemic control is much harder, although we are gradually moving up through the pack. So prior to 2010, we were always in the bottom 10 PCTs, and frankly, actually often in the bottom 5 for all measures against HbA1c. 11, 12, for the tighter target of 59, we were still in the bottom 10, but beginning to move up for the looser target. as of the last QOF year just reported in October, we're now kind of pretty much halfway up through the pack for both of them, although still below England average. So I just want to finish by, sorry, that was a mad gallop through quite a complicated journey. But I think the first thing that I would feedback from my experience is just because we're a very deprived borough doesn't mean that we can't make big impacts on the modifiable risks. We have shown that you can. I think that clearly there are some attitudinal shifts that I think are at the heart of this, so that one of the problems about being very deprived is it tends to always be about the problems that we face, but actually even in a very deprived borough we've certainly found that we had a lot of skills and assets and resources, and that, so this rather cliche thing, but catch people doing it right and actually fostering what was working. We certainly saw that very strongly in terms of some of the stuff we argue with the LMC, saying, well, nobody will ever be able to achieve that. And within 2 quarters, several practices were above the top target level. So something about not setting our own targets so low or feeling it's impossible. We took the model around general practice very seriously, and I think it's paid dividends. I guess I would say that because I'm a general practitioner. It's also paid dividends in that as we then move into the multimorbidity agenda, we actually have a frame that will support flexing in that direction, whereas if you went down the diabetes specialist service, you've got a bit of a problem. It did require additional resource into primary care. This is new work for us, and in particular that time for the conversation between the professional and the person with diabetes is absolutely key. So half an hour minimum would be my advice. And the other thing is you can't do this piecemeal. We really had to shift the whole system up scale. Otherwise things tend to default back to where they were before. Anyway, I hope that's been helpful. As again, sorry not to be able to join you in person, but just to say it can be done, and I wish you good luck in your journey. Thank you. Bye.